At the American Heart Association, the results of the prominent study were presented. And this was a negative study, but I think it's important to look at both positive and negative studies because we learn from both. This was a study that was designed to look at the effect of triglyceride lowering with a drug known as Pemafibrate to reduce cardiovascular disease risk. Pemafibrate is not on the market, and it is a selective PPAR-alpha modulator. This was a large RCT in people with type 2 diabetes and triglyceride levels of 200 to 499 and HDL cholesterols of 40 milligrams per deciliter or less. This was a huge international study. They actually screened over 35,000 people and ended up enrolling 10,497 patients. About 67% of these patients, so slightly over 2/3, had prior cardiovascular disease. Coming into the trial, the median triglyceride level was 271 milligrams per deciliter, HDL of 33, and a really low LDL of 78. The mean age was 64, a third were female, 20% were Hispanic, and 96%, almost all, were on a statin. A relatively small percent, 9%, were on a GLP-1 receptor agonist, and 17% were on an SGLT2 inhibitor. And all of these factors were really well balanced between the two groups. The baseline A1C was 7.3%, representing reasonable glycemic control. The primary efficacy endpoint was non-fatal MI, ischemic stroke, coronary revascularization, or death due to CVD causes. Because fibrates increase the efficiency of conversion of triglyceride-rich lipoprotein remnants to LDL rather than increasing their removal by the liver, in patients treated with fibrates, LDL and ApoB levels can increase. Centralized monitoring of ApoB levels was done, and ezetimibe was added if the ApoB levels increased to balance out this potential rise. Now, in terms of the results, Pemafibrate worked. It lowered everything it was supposed to lower. It lowered triglycerides, VLDL cholesterol, remnant cholesterol, and apolipoprotein C3 levels by 26 to 28%. There was, as anticipated, a 12.3% increase in LDL cholesterol and a 5.1% increase in HDL cholesterol levels. However, after a median follow-up of 3.4 years, there was no difference, none, the lines look exactly the same, in terms of the primary endpoint between placebo and the Pemafibrate, and there was no difference in any pre-specified subgroup. So basically, it didn't work. It didn't work in terms of outcomes. It did work in terms of lowering triglycerides and other related particles. Pemafibrate was associated with a significantly higher incidence of adverse renal events and venous thromboembolism. However, it was associated with a lower incidence of non-alcoholic fatty liver disease. The reason these authors did this study, in part, I believe, is because even though we have lots of other negative studies, within those negative studies, there have been subgroups that seem to respond. And one of the subgroups where we were hoping for a response was in patients with type 2 diabetes. But to just name a few of those studies that were essentially negative, there was the high-dose N3 fatty acid supplementation study known as STRENGTH. There was AIM-HIGH with niacin. There was FIELD with Pemafibrate. And all of these did show reductions in triglyceride levels, but overall, no improvement in cardiovascular outcomes. And what is even more interesting to me is that in the study known as the REDUCE-IT trial, in the icosapent ethyl trial, there was an impact on cardiovascular risk, but it did not relate to changes in triglyceride levels. So I actually think these findings are interesting, both because it's a good lesson in why outcomes trials are needed. We can improve surrogate markers such as lipid levels, but this may not matter in terms of what means the most, which is an actual reduction in cardiovascular events. And we obviously need much more research into what can we do to further lower the cardiovascular risk in patients who have high triglyceride levels and low HDL cholesterol levels. Thank you.